Hi there, welcome to this video. My name is Dane and I'll be taking you through this Active IQ series discussing the National Health Service, also known as the NHS. The aim of this series really is to help fitness professionals understand the NHS landscape and to discuss the opportunities and possibilities for us as exercise professionals. So this video is the first in the series and we'll discuss the NHS structure and its function. But to do this, we'll cover these 6 areas. So we're going to talk about the NHS history, its structure, the organisations inside the structure, public health and social care, funding, and then current challenges as well. Here you'll see a picture of York Hospital. So this is where I've worked in a variety of roles since 2012. So before we begin, let me introduce myself properly. So my name is Dane Vishnubala. So first and foremost, I'm an exercise professional. My first job was in 2002 for what was known as Bromley My Time, or later My Time Active, as they're known now. So I worked as a personal trainer, fitness instructor, studio cycle instructor, a range of roles. You name it, I've done that in that role. And then in 2004, I started my first NHS role. So this was as a healthcare assistant, a theatre assistant and a porter, so pushing trolleys and beds, and that was in Sidcup. Given my love of exercise referral and cardiac rehab and that NHS experience, I decided I wanted to study medicine. So in 2005, I went to York University where I studied medicine. And I continued to work in the fitness industry for around 20 hours a week, and I still continue to work and teach within it now. So my main roles now are as a consultant physician in sport and exercise medicine, an NHS England training programme director in sport and exercise medicine. So this means I train people to become specialists in sport and exercise medicine. I have an academic clinical role at the University of Leeds and the University of Derby, and I'm the Chair of Education for the British Association of Sport and Exercise Medicine. I founded Core Fitness Education, so an active IQ training provider, approximately 15 years ago. And I put my main research interests there in the QR code if you're interested. My main research interests are education, sports medicine and physical activity. So again, you can see my publications through that Google Scholar link. So I hope you can see there's been a range of experience, and I hope both my experience in the fitness sector but also in the medical sector will help us to navigate this series together and provide you some insight which you might find helpful. So let's get started. So the NHS was born in 1948, and at the time it was the first universal healthcare system to be free for everyone. So while as many of us know, it has its downsides and challenges, like many in the UK, I'm very proud of the NHS, and we know that 9 out of 10 people in the UK agree that the healthcare system should be free of charge. The NHS treats over 1 million people a day in England, and it's the site of many firsts. It was the first of Britain's kidney transplants in 1960. It was Europe's first liver transplant in 1968. It's overseen the national vaccination programs such as measles. It offered the first meningitis C vaccine in 1999 nationally, which was a big global first. It oversaw the first IVF baby in 1978. So it's been a real source of national pride and importance for a long time. Understanding the NHS, however, is tricky. It's grown, it's evolved, and it's changed. And as healthcare changes, technology changes, and medicine advances, it has to change and evolve in order to stay current. And it has been revised and changed by multiple governments to date. So the NHS workers have changed over time. Their roles have changed, the responsibilities have changed. And even during my time of practicing medicine, which is the last 15 years, we've seen 3 big changes. We initially saw primary care trusts, which were then abolished in 2013. We then saw CCG, so the clinical commissioning groups, and then we've seen this move to an integrated care system, or ICS. And these terms keep changing. Sometimes the functions change too, but keeping on top of these things is really a full-time job sometimes. So let's look at the current NHS structure, which has evolved over the last few years. So firstly to say, this focuses very much on England, given NHS Scotland, Wales and Northern Ireland are devolved and operate slightly differently. The diagram, however, shows the key structures and organisations involved, and you can see at the top of that tree we've got the Department of Health and Social Care, and this department, so DHSC, allocates funds to NHS England, which you can see below, which in turn allocates funding to the NHS via the Integrated Care Board, so ICBs, which you can see here, which are part of the ICSs or Integrated Care Systems. We'll come back to this in more detail. So providers of NHS care are then accountable to their ICBs, who are then accountable to NHS England. The CQC is the regulator and has regulatory oversight over healthcare and social care providers and monitors performance. So if you go to the CQC website, you can read reports about GP practices, hospitals. So really consider it the Ofsted reports equivalent of the healthcare world, if you're familiar with Ofsted and education. Below ICS, you can see that there is local or place-based level type work, and you can see that just below. So these include primary care networks, which are essentially a group of GP practices in the same area working together. You can also see local authorities, and there are 317 in England, and these are local regions, and they're important for a range of things. So everything from social care, schools, housing, planning, and the councillors there work with local partners, local people, businesses to agree and deliver local priorities. Underneath this layer, you can then see the service providers, and here you can see the primary care trusts, so including GPs. You can see the NHS trusts and foundation trusts, so the hospitals. You can see the private providers. You can see the local public health services, so things like weight management services. You can see the social care provider as well. So I hope this gives you a nice overview to the structure of the NHS in England, and then we'll discuss some of these key kind of elements further as well. So first of all, NHS England. So we've already talked about the fact that it is effectively an arm's length body for the Department of Health and Social Care. It emerged with NHS Improvement, and so as a combined organisation, it oversees the commissioning of healthcare services. It allocates budgets to different areas of the NHS, and it also oversees different providers of NHS services. It's a fairly large, unwieldy and complex organisation, as you can imagine, given the range of tasks that it does, and it works with a range of organisations and partners, as outlined in the previous slide. So the Health and Care Act in 2022 was a big change and a big difference. So it changed the NHS structure in England, with every area now being covered by this Integrated Care Board or ICB, and also an Integrated Care Partnership, which together is known as the Integrated Care System or ICS. So the ICS has replaced these clinical commissioning groups that used to exist, or CCGs, and have taken over the majority of their function. However, one of the big differences is that ICSs were intended to be different in the way they made decision making, unlike a CCG. They brought together more partners and a wider range of partners than CCGs, which were heavily GP led, versus the ICSs were bringing together a range of people that actually included hospitals, for example, as well. So there are 42 ICSs that make up the integrated board and an integrated partnership. So ICS is the integrated board and the integrated partnership together form the ICSs, and there are 42 in the country, and you can see that on the map here. The ICB oversees and performance managed by the NHS England, with Care Quality Commission or CQC independently regulating all healthcare and social providers. So we've talked about this before as well. By having the integrated care partnerships, this is really important. One of the big shifts or differences. This is where local authority representation, local partners were also integrated into the healthcare process. So the hope was that this would allow more joined up thinking, a more integrated approach, and a real kind of element of understanding local needs that really local authorities probably do best. So this really ensures that kind of wider health is considered, as well as, more importantly, public health and social care needs as well. So essentially, I think this can be really well explained by a government paragraph for ICS that they've described it as, which is the integrated care systems, or ICSs, are geographically based partnerships that bring together providers and commissioners of NHS services with local authorities and other local partners to plan, coordinate and commission health and care services. They are part of a fundamental shift in the way healthcare systems are organised, away from competition, organisational autonomy, and towards collaboration with health and care organisations working together to integrate services and improve population health. The more joined up the approach, which I feel is the direction of travel here, the more the patient is being considered as a whole, and you can see there's a bigger driver towards prevention here as well. So when we talk about primary care, we really do mean the local community. So there's a range of people that could be considered part of primary care. So you've got your GPs, you've got pharmacists, dentists, opticians, and we have seen historically over time that, pharmacists are taking on some of the work that GPs would have perhaps historically done. And as healthcare evolves, it's no longer as simple as it used to be. GP and the community manage heavily complex patients and decisions, and there is a big shift and a move to take more and more things out of the hospital and into the community as well. And we've seen that shift across paediatric, so children and elderly care as well. And GPs are managing more and more conditions historically that were managed in hospitals. Now, the GP could be argued that they are the primary care hub, and patients do generally see their GP first, or their GP practice, who will then coordinate and refer if it's more complex and requires secondary care input or other services. But ultimately, the GP strength is in that continuity care, understanding their community, understanding their patients, and getting to know their patients quite well. And while this is one of the biggest challenges with the bigger pressures put on the NHS. So we've now got, with the challenges of a growing population, changes in NHS funding, reduction in GP numbers, complexity of patients, all being thrown into primary care. The pressures are high, and perhaps general practice is struggling. And GP practices are managing a range of chronic diseases where physical activity and lifestyle modifications can have a huge impact in primary and secondary care disease prevention. So secondary care, so this is essentially hospitals, and these can be split further into local hospitals, many known colloquially as district general hospitals or DGHs, and teaching hospitals, which tend to be a bit bigger. Tertiary hospitals tend to have specialist services for the region. For example, things like heart bypass surgery, spinal and brain surgery, so specialty like neurosurgery, tend to occur in tertiary hospitals. So they tend to all be grouped together. And this makes sense because you want things that are less common or highly complex and need high volumes of skill to maintain. You want them to come to one place where the people doing them have seen lots of them and can manage them well. So, for example, where I live in York, you would go to Leeds or Hull for these tertiary services. So finally, wanted to talk a little bit about public health and social care. So public health is a very, very key part of healthcare, and sometimes forgotten when we're being so reactive with the problems that we see. And it's critical for preventing disease, but reducing inequalities. And we know we have many inequalities just in physical inactivity alone. We know we have inequalities around the fact that females are less likely to be active. We know that potentially those from more deprived backgrounds are less likely to be active. We know that people from certain ethnicities are less likely to be active. So again, reducing inequalities is key. But just the overall improving of population health. So things like physical inactivity, smoking, improving air quality all come under this remit of public health. So really important role. Changes take a long time to necessarily sometimes show effect as well, which is one of its challenges. but since 2013, public health has sat under the local authority and moved out of the NHS. Social care, to try and define this, is providing help, care and protection from harm for people with physical disabilities, learning disabilities or physical or mental illnesses. Now, as you can imagine, with an ageing population, particularly given if you look at England, the number of over 85s has gone up by a third in the last decade and is likely to double in the next 20. So social care requirements, so people's need for further support, is going to continue to rise. So again, this really needs integrating well into the wider healthcare system and considering. But again, the key thing to get across here is prevention is key. We've got an ageing population. Doing preventative work well will pay dividends later. And I guess this is where the exercise or health industry or our industry could play a big part. And these are where some of the skills we're going to talk about as we go through this series are so incredibly important. But ultimately, a lot of health behaviours anyway, the kind of themes, the skills, the knowledge, there is significant overlaps. And I'm really passionate that I think this is where the health and fitness industry can make a difference. So that we will cover this a little bit further soon as well. So let's talk about funding. So funding comes, as we said, from the DHSE budget. So as you can see, money does go to other departments, as you can see in the diagram in the green. However, the majority of it here comes to NHS England, and then most of the commissioning resource allocations then go to integrated care boards, or the ICB. So you can see nearly 107 billion in this case, with the remaining resources, so around the kind of 41 billion, then going through NHS England directly to commission services on a national level. And you can see that includes general practice, but also maybe prison healthcare services, amongst other things. Probably to go back and just point out one thing, in terms of generating income to create this DHSE budget and funding, most of this is through taxation, but also through national insurance contributions, which, as some of you may know, did increase slightly. So finally, long-term challenges. NHS there is constant challenges in these constant problems. And if you look at the political landscape, every government sets the NHS as a high priority. In fact, recently was quoted to say that the NHS is broken. So there are many long-term challenges. We've got a growing and ageing population, chronic diseases on the rise, health inequalities appear to be getting worse. All of this adds pressure onto the NHS. And as you can see from the data here, things like elective care, so waiting for planned things, the wait times are rising, A&E wait times are rising, cancer referral times are taking longer, and all of this potentially leads to poorer patient outcomes. So for us, these are things we want to change. And again, if we're talking about prevention and all the things that come with that, this is where potentially there's windows of opportunity for us in the exercise, health and fitness industry to really make an impact, to make a difference, or to contribute towards this problem. So I hope you found this initial video useful in terms of understanding the structure and the key elements of the NHS. In 2018, the Prime Minister at the time, was Theresa May, asked the NHS to produce a 10-year plan to improve access, care and outcomes of patients. And this is the NHS long-term plan that was produced and published in 2019. So alongside that, there's also now the NHS long-term workforce plan, which was published in 2023. And these two documents are really key documents to understand the direction of travel and to really explore the role that we could potentially play as a group and how we might engage or interact with the health sector. So I look forward to discussing this with you on the next video. So do feel free to connect. I hope you found this useful, and I'll see you in the next video.